Folks are filtering in. We are so happy to see them. Yay. All right, and we'll start in just about 1 more minute. Kelsey, you doing okay? Okay.
Yep,
great.
I'm doing well, thank you.
Wonderful. Okay. All right, we are live streaming on YouTube as well. So for anybody who might be watching, just in case, if you get kicked off, you can go over to our YouTube page or our Facebook page and see us there. I am going to begin. Thank you all for joining us and welcome to the Greensboro History Museum's March webinar series, New in Town, Immigration and Refugees in Guilford County. My name is Catherine Johns. I am the tour coordinator and resource specialist for the Greensboro History Museum at the Education Department. During the March webinar, we will be joined by members of the UNCG, or UNC Greensboro's, Center for New North Carolinians. We are so pleased to have so many of you with us in attendance today, and none of this would be possible without the Greensboro History Museum Guild, the City of Greensboro, and the Libraries Department. Any views, findings, or recommendations expressed in today's program do not necessarily reflect those aforementioned entities. We are also extremely pleased to have any guest audience that joins us. If you all will take the time to view the bottom of your screens, I'm sure everybody is familiar with Zoominars now, but just in case you are not, we are going to have a brief rundown of what you can do. You'll see the Q&A icon at the bottom of your screen. By selecting this option, you can type in questions for our panelists today. Once you've typed in your question, hit the enter button on your keyboard to submit it. We have reserved the latter part of our program to field these questions. This evening, we welcome our panelists for today's webinar, which will also be featured as an archive in our History Notes podcast at a later date. However, it is also made available immediately, like I said, on the Greensboro History Museum YouTube channel. At your convenience, please visit www.greensborohistorymuseum.org and select the tab Discover and Learn to hear the podcast when available. For more immediate viewing, select the YouTube icon at the top of the page to access the YouTube channel on our website. Today, I apologize. Something popped up on my website. Okay. Today's presenter is Miss Kelsey White. Miss White is a public health social worker and program coordinator with the Immigrant Health Access Project at UNC Greensboro Center for New North Carolinians. She is proud to support a dedicated team of multilingual, multi-generational community health workers who promote health equity alongside immigrant and refugee communities in Greensboro.
Thanks so much, Catherine.
I'm so happy to have you today, Kelsey. Thank you so much. And I am going to hand it fully over to you. Hopefully everybody can see the screen to our side right now.
All right. Thank you so much. I'm really thrilled to be here and be part of this CNNC series. As Catherine mentioned, I'm a public health social worker. I went to UNC Chapel Hill and then moved to Greensboro in 2017 when I became the Immigrant Health Access Project Coordinator. So somehow it's already been 4 years that I've been with CNNC. And I began that work focused very much on outreach to the Latino, Hispanic, Latinx community, since I am a Spanish speaker. However, since then, I've had the opportunity to expand that support to other communities as well and really get to know people from just a wide range of communities living here in Greensboro. So I laugh because up here, I grabbed a screenshot of our website that had an article saying, meet the new CNNC staff. And the 3 of us pictured here have all been at CNNC for close to 4 years, if not 4 years. So a few things I'd like to do tonight are introduce you briefly to CNNC, since I am the first one of our staff doing this series, give you an introduction to immigrants and refugees in Greensboro. We'll talk about social determinants of health, some immigrant health outcomes and challenges, the barriers people face, and then some of the solutions that we see, in particular here locally. So the Center for New North Carolinians promotes access and integration for immigrants and refugees in North Carolina. And we do that by bridging newcomer populations, which is another word that we use to refer to immigrants and refugees, with existing communities already living here through our direct services, research and evaluation, and various kinds of training for service providers, as well as for community members and in collaboration with community members. We serve over 2,000 individuals annually, including newly arrived immigrants and refugees, those who have been here for years or for decades, and also subsequent generations of some immigrant and refugee families. You can see to the right our 9 core program areas, as well as a photo of our newest community enrichment center, which is out off of West Market Street. I always share this slide now in every presentation that I give for a lot of reasons, but mostly because CNNC exists because migration is our history, our reality, and our future as North Carolinians, as people living in the United States, and as humans. It's just a part of our reality, and it always will be. The reason, secondarily, that I love to share this is that William Swing Lacey, who said it, is a former Director General of IOM, the International Organization for Migration, but he's also a native of Lexington, North Carolina, right down the road, and he graduated from Catawba College before going on to Yale and other places. So I love how this brings together my worlds and my work, and also this place where we live and the global community. So once again, a quick overview. I am not a legal professional. My colleague Betsy is going to take care of that in a few weeks. But just to begin, I find it's helpful to give some different ways to think about who immigrants and refugees are. And one of those is looking at the legal framework. So an immigrant essentially is anyone born in a country other than this one who comes to the US intending to stay here permanently, to relocate here. So usually people come through different pathways that are often related to family, employment, or humanitarian reasons. This includes, so those are the sort of the legal pathways that people can use, the sorts of visas, the sorts of pathways to getting a green card, and ultimately citizenship. Refugees are a particular subset of that humanitarian group. So people fleeing persecution because of their membership in a particular group. So we think of refugees as an example of forced migrants, people who did not really have a choice. And refugees happened to be granted a special protected status by the UN that enables them to enter into a resettlement program if they're very fortunate. And ultimately for the people who come here to Greensboro, that's how they come as resettled refugees. This I did not include and should have unauthorized immigrants or undocumented immigrants. These are people who are here and often come for many of the same reasons that even perhaps refugees would come, fleeing violence or fleeing instability in their home country. Many people, depending on where they come from and depending on the dynamics at the time, don't have access to the status of refugee. And so they face a lot of other challenges based on their lack of a legal status here in this country. So too long, don't read. All immigrants or all refugees are immigrants. Not all immigrants are refugees. And despite the title of this webinar series, not all newcomers are new in town. So I've worked with many, many people who've been living here definitely for longer than 4 years like me, and some of them for longer than I've been alive. So I bring all of this up to say that immigration status is one of the things that directly affects people's health and their health access, and we are going to talk about why. Just a quick snapshot of the diversity that we have here among immigrant and refugee populations. So you can see that 12% of our county residents were born in another country. Mexico is most common, but there are countless others. 118 plus languages represented in Guilford County schools. The top 10 of those, Spanish, Vietnamese, Urdu, Arabic, and French, all of those except Urdu are spoken by CNNC staff, among other languages. And then 142 plus cultural and ethnic groups represented also by students in Guilford County schools. So this gives you a big picture of that diversity. And then I also just included a list of some of the countries represented and languages represented among the clients we served in our health access program just this past year. So all of these people, we served at least one person from all of these places and at least one person who spoke one of these languages. Some of them are languages I didn't even know about before I moved to Greensboro, like the Montagnard languages from Vietnam, Jirai and Rade, among others. Also Sango from Central and West Africa. These are new to me, so that's been one of the cool things that I have learned through this job.
I am so surprised at the diversity of that list, Kelsey. That is outstanding.
It's pretty wild. Yeah. So we can look at legal definitions and we can look at demographics and where people come from, and then we can get to know people personally and work with them. And these are not real people per se. These photos are just stock photos. But these are composites that I have created over 10 plus years of working with different communities. And I like to share this because it represents, again, that diversity, and in my world, sort of the different sort of health profiles that people can have. Every single one of these people in real life would have somewhat different access to healthcare based on their age, how they came to this country, their household composition, income, any number of other things. So I just like to put a few faces, even if they are somewhat fictional faces, before you, to just reiterate the humanity, just to reiterate how different we all are and yet how much we share and how much immigrants share in their healthcare access experiences. So I want to differentiate between health and health access, which is what we focus on in my program. The World Health Organization, that we've all heard a lot about this past year, defined health in 1948 as a state of complete well-being. So they say it's not just the fact that you're not sick or you're not disabled. It means you are fully well, physically, mentally, and socially, which is a pretty lofty goal. But they put it out there in 1948. When we usually think about access to health care, we're addressing one piece of that. And you can see that to get over here to realize access, where you're actually able to consistently get to a doctor or other health professionals to meet your needs, it requires all these other things to work together. And we're going to look at these in more detail. So you can see what seems easy for a lot of us, I need to go to the doctor, I need to have my yearly physical, can quickly get very complicated because it requires all of these things to line up, both with the entity providing the care, whether that's a hospital, a health system, an individual provider, and with the entity seeking and receiving the care, so the community member who needs the service. So a lot of, public health scholarly terms here, but what it comes down to is, are the services approachable? Is it obvious that they're there? Is somebody doing outreach? Are they giving information? Do the people who need the health services perceive that information that's there? So are they aware of the clinic as a place to get help? Are they aware of screening tests as a concept? So these things have to line up. Again, acceptability. So the care, when I go to the doctor, does it feel like I'm welcomed there? Is the provider someone I can talk to? If I'm a woman who cannot see a male provider for cultural reasons, or other reasons, is there someone of the gender that I prefer? Are the services offered in line with my own health practices, my beliefs? Acceptability, availability and accommodation. So where is the clinic located? Is it down the street from me? Or is it across town where I'd have to either have my own car or take multiple buses? Is it open when I'm off work, which is only after 5 or on the weekend, or do I have to take time off work? These are the things that sort of line up here, right? What's my mobility? What's my environment? And how does the clinic line up to those needs? Affordability. I don't know why I wasn't thinking, but I did not expect to become really some sort of financial counselor when I started working in health access here 4 years ago. That is one of the biggest conversations that we have at any point is, I'd really like to get this healthcare, but I'm afraid that I'll get all these bills and I won't be able to pay them. So I'd rather not go there. This is problematic in all kinds of ways, but the point is that affordability is one of these 5 A's of access, right? Is the person able to pay something for care? Do they have insurance? Do they have the option of insurance? Is the provider willing and able to accept the payment that they're able to offer? So these things have to line up. Appropriateness. So this again, is really just the quality of the care itself. Is it appropriate to the needs of the community? Is it technically up to speed based on what the community needs? Will it meet the need? So all of these things, you can see what the healthcare entity has to have and what the community has to have in order for approachability to mean that the community can perceive, in order for affordability of care to mean that the community can pay. All of these things have to align. And that's how we get consequences of healthcare and health outcomes ultimately that people experience. So again, when we talk about health access, we're talking mostly about access to these clinical services, like going to the doctor for your physical. And that's very important. So I don't at all want to say that that's not important. It is, of course, life-saving in many instances. And health services are something that some of our clients at CNNC may never have had access to, or maybe have accessed once or twice in their lives. So this is a big deal. At the same time, we know in public health social work that a lot of different factors besides healthcare services themselves impact our overall health, and even the timing of our lives, the timing of our deaths, whether it is a natural life course or whether we die prematurely. So Kaiser Family Foundation has these wonderful graphics that show this breakdown, and that is they estimate that healthcare itself, the services we go to receive, accounts for about 10% of our risk of premature death, while the remaining 90% has to do with these sort of interplaying factors like our environment, our genetics, our individual behavior. And what I always have to stop and think about is the fact that my genetics, can't do a whole lot about that. My environment, I can do some things about that, to a degree. My individual behavior, I have the most control over that, but it's also constrained by my environment and sometimes by genetic factors. And individual behavior and environment affect whether I can get the healthcare to begin with. So it's all connected. And therefore it's encouraging to me that locally, as well as more widely in my field and other related fields, that we're starting to talk more and do more about the social determinants of health, which are all those other parts of our lives that affect whether or not we can have a decent quality of life and maintain our health. So these are the conditions where we live, where our children are born, where we play, work, go to school, all of these systems around us. And they highlight here economic stability. So my employment, my income, do I have access to insurance? My neighborhood, if I am recommended to do daily exercise and I live in a place with no sidewalks, or where there's a lot of violence, or where I just feel like I'm being discriminated against every time I go outside, I probably won't get to enjoy the things that a safe built environment could offer me. Education is a big predictor of health status and health outcomes. If I can't read or write in the language that the information is being presented to me in at the doctor, then that's a problem. Food access, community and social context. I like this one because CNNC really is looking at all of these, but the community and social context in terms of social integration and support, systems of support, is really what we're about in all these different sectors where we work. And finally, the healthcare system itself can be a determinant of health. We're about to talk even more about that, but again, a thing that I didn't expect necessarily to be talking about on a day-to-day basis was helping people understand that they are not the only ones having a frustrating experience or a traumatic experience with the healthcare system. People take it on themselves. They think they're doing something wrong. And we have a lot of conversations about, there are great things about our health system, and there are a lot of things that aren't working. So let's work through these things together to the best of our ability, but don't blame yourself, because it's a whole system that we have to work to make better.
And Kelsey, I'm going to interrupt for 1 second just to remind all of our attendees that if they want to ask a question, we'll be answering them at the end, but feel free to put in questions now, okay? So that if you see something that Kelsey is presenting on and it sparks a question that you want to ask, please shoot it down to our Q&A that's at the bottom of the screen here, and we will get to it at the latter half of the portion of the presentation, okay? Thank you so much, Kelsey.
Yeah, thank you. I'm used to doing presentations in big rooms of people, and I love for it to be conversational. And so I hate we can't do that today.
I miss my big rooms too.
Yeah. So all the things that we mentioned on the previous slide, employment, neighborhood, education, all of those are connected to immigration in some way. But what's really interesting is that people are starting to think about and study immigration, the experience itself, as a social determinant of health, as something that is so unique from any one of those other factors that it needs to be looked at on its own. And that's because although, as I said, immigration stories are all different in important ways, there is a shared set of experiences that most people do tend to go through that involves an almost complete realignment of life, of daily life, as these authors said. So you're confronting, everything that is familiar, and you're trying to reimagine and reacclimate yourself to it in another place. As I mentioned more generally about limited behavioral choices, the experience of immigration means that sometimes and often just being an immigrant, being someone who wasn't born here, limits your choices the moment you arrive. And it places individuals, I love this phrase, although not what it refers to, in an ambiguous and often hostile relationship to the state and its institutions. So some of the institutions and systems that I, as a white woman born in South Carolina, with class privilege, with educational privilege, the things that I can expect to serve me and work for me don't work for people who come as immigrants and refugees in the same way when they work at all. And these are important things to recognize as we're thinking about, why don't people want to go to the doctor? Why don't people follow up with appointments? So many no-shows, frustrations that I hear sometimes from providers that are, of course, normal frustrations for somebody trying to provide a service, but it really takes looking at the big picture to think about really how we're constructing these institutions like the healthcare system, and whether or not we're creating them in a way that feels welcoming and useful, or does it feel ambiguous or even hostile? The other thing that I want to mention about the migration journey and things that people may experience, there is an idea called the triple trauma paradigm that talks about the different stages of migration, and again, sets of experiences that people might have in common. This in particular shows a journey that is more tailored to a refugee or a forced migrant, someone leaving a conflict zone, a failed state, and the sorts of things that might impact their health, both physical, mental, psychological, social health. And again, can vary widely from person to person, but some examples are in the country of origin, especially someone who ultimately will become classified as a refugee. They may be experiencing harassment, threats, actual violence, living through a conflict or a war, torture, or having family members experience torture, malnutrition, diseases that we consider rare or neglected, so things that only happen in certain parts of the world, lack of vaccinations. I think we can relate to that more broadly here right now, so you can see how this can extend across this continuum. But we're talking about here particularly sort of basic childhood vaccinations that are widely and universally available here practically, that are sometimes not at all available in other places. Poor reproductive care, so maternal mortality and child mortality being a big cause of death globally in some of these countries of origin. Again, also increasingly a concern here. So then the next stage is the escape or the journey. So you're traveling from your country of origin to the new country, and what are you facing along the way? This looks very different. Maybe you're just getting on an air, maybe you chose to migrate, you were not forced, you are not a refugee, you didn't have to flee violence, so you got on an airplane and came here. That's ideal. But maybe you walked through the desert and swam across a river. Maybe you were trafficked. Maybe, in a ship or a train or a truck. Maybe you came by many other means. I'm always amazed how creatively and how resiliently people find a way to get where they want and need to be. Unfortunately, that means for people's health that they're still facing violence as they flee, often physical trauma, either some kind of, unintentional injury, or often some kind of intentional injury from someone else. Sexual trauma is something that is very frequent. For those traveling, on foot, dehydration, exhaustion, unsafe traveling conditions. I know we have all heard stories about that. And then for people, for example, living in camps or living in sort of halfway points, way stations along the journey, living in crowded or sometimes unsanitary living conditions, all of this has an impact on both health in that moment, but your longer term health and your overall sense of well-being. So you get to the country of resettlement or relocation. A lot of people experience at first sort of an equivalent, except a very big picture of culture shock, where you are honeymooning. You're here, finally here, things are going to get better. And maybe, and hopefully some things do get better. Maybe, hopefully everything gets better. But unfortunately, we know that the trauma or the stress doesn't typically end with relocation or resettlement, because people report having a lot of integrative stress. So this stress of constantly having to learn new things, trying new things that you're not comfortable with, interacting with people who don't necessarily share your language, trying to find the foods that are familiar to you, trying to maintain housing, trying to maintain safe housing that's not a threat to your health or your life. Being either unemployed or underemployed because the jobs available here may not match skills that you have at home. When you do find a job, often it could be in an occupation that's very risky. So that itself poses a danger to your health. I'm thinking here about many of the people we work with who are employed in meat processing, which is desirable because it's a regular high-paying job compared to much of the other opportunity that's out there. And as we've just seen in the past year, it's not only inherently dangerous, many of the positions themselves, but also if there is a respiratory virus pandemic, then it's not an especially safe place to work. So you're at increased risk. And finally, the barriers to clinical care that we've talked about and we'll touch on a little more as well. So the triple trauma paradigm basically says that traumatic stress is possible throughout this migration journey. So whether it's the country where you started or the country where you're now living, there are things that give exposure to trauma and exposure to stress, which in turn have either a direct or indirect impact on your overall health. And I think as service providers or people looking in from the outside, working with refugee and immigrant communities or interacting with community members, I think there can be an assumption that I mentioned at the beginning, which is, well, people are here, everything's better now. And as I say, a lot of things can be better. And I'm really privileged to be able to witness some of those things. And based on people's own narratives, based on their own reports, the stress and the trauma that they experience here after getting here, and as they continue to try to acclimate and find their way and build a life, is sometimes so much more immediate than whatever violence or other trauma they faced in a country of origin, that it actually becomes more traumatic to them in terms of their day-to-day functioning than that initial set of traumatic events. So I think that's something for us to keep in mind and not assume, once again, that we know somebody's experience and that, you know, they've gotten past all the bad stuff and now everything is fine, or vice versa. You know, this isn't to say that everyone experiences trauma or identifies it in that way, but it's just to complicate things a little bit as we think about immigrant health.
I think it's so interesting that you use the meatpacking industry as the example, since we know that that has just been going on as an immigrant place for immigrants to work for literally centuries now, right?
Yep. Yeah.
It's incredible.
Absolutely. Absolutely. So again, this just shows sort of how at every step of your journey, no matter where you're living in your migration journey, these are some of the different things that differ for people and can impact our health. So turning to our local community and health outcomes, themes in health that we see, I'm thankful to the Guilford County Community Health Assessment the health department does regularly. The most recent report that came out in 2019 had these themes from some focus groups with immigrant and refugee community representatives. And these are just really great summaries of what I see every day and what we talk about on my team of community health workers. So theme number one, immigrants and refugees share many of the same health concerns, though with important differences. So by this, we're talking about concerns like chronic conditions, hypertension, diabetes, heart disease. These things are, of course, some of the most prevalent kinds of diseases that we have here in the US. And we have a lot of clients in our health access project that also have these conditions. Some of the important differences that they highlighted were, you know, how are people used to taking care of these conditions or their effects based on their own traditional practices or their health beliefs? Are they, you know, we like to prescribe medication, which often, again, can be a life-saving tool and life-improving tool. Is everyone comfortable taking medication? Maybe, maybe not. If I tell someone, well, to manage your diabetes, you should go out and get some exercise every day, and she is a woman who is not comfortable, or you know, it's not the practice to go out alone and do physical activity in front of strangers, then we're going to have to talk through some other options. Same thing with nutrition. So of course, nutrition is key for managing any health condition or preventing health issues. And often the nutrition advice that we get from professionals here is very tailored to our kind of mainstream palate. Sometimes, places we might refer people to get food assistance, again, tailored to a very kind of mainstream US grocery store palate. And so if the foods that are recommended to you just aren't familiar at all, then that's probably also not going to be an effective way to manage a chronic health condition. So just a few examples of that. Something else that we know is, as a big group, immigrants and refugees, first generation, tend to come and have a better health status when they get here than in subsequent generations of their families. So people may be coming from places where they're walking, they're working outside, they're eating food that's grown closer to them or fresher, home cooked, not fast food. So some of those things can actually be protective factors. Coming here, we rely on cars. There's a lot of processed food that's easy to access. Kids especially tend to pick up on the behaviors of those around them and mimic those behaviors. So when you're going to school and people are eating a standard American diet and playing video games and whatever else that they may do, as the generations go on, we'll see their health status and health profile start to look more like that of a typical person born in the US. So theme 2 was around access to information. We get a lot of health information thrown at us all the time, whether we're in the doctor or not. We have commercials for pharmaceuticals in this country, which is like a very bizarre thing. You go to the doctor or the hospital, you come away with a sheaf of papers. If you want to apply for health insurance or for some sort of benefit or program, often there's a lot of documentation to read or digest as you're making a decision. So we like having information because that helps us make informed decisions, and there's nothing wrong with that. But there is something wrong with expecting someone to digest a lot of really complicated information in a language that's not theirs. Or if they don't read or write in any language, that's a whole additional barrier, right? So making sure there are ways, both written and visual formats, but also, interpersonal formats for sharing health information in a way that's actually able to be comprehended. So I have worked as an interpreter in the past, and there's always, in many visits, there's a point where the doctor is using their technical language, which it puts me at ease to a degree. I'm glad that they are well studied and well practiced and know the technical terms. And I can't tell you the number of times that I've been interpreting for someone, and I'll interpret something the way I'm supposed to, which is, which is what the provider says. I tell the patient, and they're like, no. And I know it was the technical word in Spanish, but it didn't get at the heart of the concept. And so asking a provider to restate something in terms that are relevant to how this impacts someone's quality of life, let's just break it down into the actual functional reality that you're talking about. If I don't take this medicine, what can I expect to feel in my body? What can I expect to see with my health? So that's, again, one example of how critical accessible health information is, and thinking outside the box. I'm somebody who writes a lot of things down and tends to share information that way, and it's just not what works for everybody. So that's something to keep in mind. And so theme 3, accessible, affordable, timely, culturally competent care remains a barrier. This is what we're going to move into now. So when we think about barriers to access, they are on multiple levels, and I've highlighted a few of those here. So there is this individual interpersonal level that we often think about, and that is, if someone's having a hard time accessing healthcare, then they probably just don't know a lot about the health system, or maybe their culture doesn't line up with our health system. Both of those can be true. Limited financial resources, absolutely a factor. work and childcare schedules and all of those just day-to-day logistics that we all have to think about are absolutely a factor. The language that the individual speaks is a factor. And then there is an awful lot of fear and mistrust and shame and stigma. And we think about shame and stigma, I think, in terms of things like mental health, substance use, sometimes reproductive health issues. But I am talking about people telling me, I don't want to ask for help with my primary care doctor bill because I don't want to be a burden. So I'm talking about a sense of shame and stigma that goes beyond any particular topic that might be uncomfortable, and just a general feeling of, if I ask for help, I'm going to be seen as a burden. I know people already have stereotypes about me, and so it's better for me to just deal with this on my own. So that's very real. And where does it come from? I see it coming from really from the big policy societal level of things in many ways. So we have laws that limit people's insurance status based on their immigration status. We ask for documentation for certain programs that not all people have access to. Immigration enforcement activities can make people afraid to seek services, both to just physically be out in the community, but also afraid to provide information that they fear may be shared with immigration authorities improperly or on purpose. And then just, anything you already know about manifestations of structural racism in this country. Immigrants and refugees tend to be racialized into those same categories that we have constructed here in the US. And along with that, there is widely, there is this undercurrent of xenophobia, sometimes not even an undercurrent, right? We've seen open xenophobia expressed widely in recent years. And so all of these things, I think, filter down to that individual level. Again, practically speaking, at the community level, we're really lucky here in Guilford County to have a program called the Orange Card, to have community-based nurses who are stationed at different places around the community. So we've got some things in place to reach people who might otherwise just not have access at all. Even so, we are part of the American healthcare system, so it's quite complicated to navigate even at this local level. And of course, people have logistical challenges like transportation, the hours available. I put language access in its own category because it is such a huge issue. If places do offer interpreters, people love having a face-to-face interpreter. It's the best practice. Often now it's video interpretation, which is wonderful and has its own challenges in terms of internet connections, visibility, just a general feeling of comfort. Like, can I feel comfortable with this person on a screen? So language access is also an issue when providers just don't offer language services, which is something we face pretty regularly, and try to work on advocating and providing some direct services in those cases. The capacity of clinics, especially for people who are uninsured, sometimes the wait times can be very long. And again, that's just in part, that's reality, right? There's capacity is what it is. And this does have a disproportionate impact on the folks we serve, who tend to be among those most drastically affected when they can't get into care as soon as they need. And unfortunately, there are times when we have experienced with our clients or heard from our clients about overt discrimination. So going to organizations and being discriminated against, perceiving that as based on their immigration status or something else about them. And we also know that all of us have implicit bias, right? And so sometimes we may be interacting with people in a way that's not welcoming or that otherwise turns them off to seeking services. And we may or may not be aware of that. So these are all things for us to think about at every level. luckily, there are best practices. There are some solutions and approaches and resources that are available. And I'll highlight three things here. Generally, one is the framework of cultural humility, which is something that goes beyond what we call cultural competence. Cultural humility is this practice of saying, I'm going to be learning for the rest of my life. I can't become competent in someone else. I can't become competent in someone else's culture. So what I'm going to do is examine myself and learn about myself and observe my interactions with people and work to create interactions where I am where I'm listening, where I'm learning from someone so that we can work together. This helps us to acknowledge power imbalances in relationships, which do exist depending on many things about us, where we're positioned in the world. And this is a practice that has been developed really well by the Indigenous Health Service in Canada. So I've linked Culturally Connected, which is a Canadian resource that was developed out of work with First Nations and intended to promote health services that are culturally humble and that work toward cultural safety, which is sort of the ultimate goal of all of this. As far as language access, the Civil Rights Act of 1964 has Title VI, which requires entities receiving federal funds, including things like Medicaid, to provide interpretation services. So I've linked some information there about Title VI. We know that it's not enforced. It's not enforced robustly in many cases, unfortunately, but it is there. And so I always like to point it out to people so they can learn more about what the requirements are and as well ways that those requirements can be met by organizations. And finally, the community health worker model, which is what we have at CNNC in the Health Access Project. So this model goes by many different names, but essentially it refers to frontline health workers who come from the communities they serve and so are able to build more trusting relationships, share a language, share cultural reference points, and generally make services better and make community members more comfortable in asking questions and seeking services. So I've linked a general CHW resource here. I also have more about our health access project, which I'm going to cover briefly so we can get to some questions, because I'd really like to hear from y'all and see what you'd like to talk about. So just briefly, Immigrant Health Access Project is one of our programs at CNNC. We're focused on promoting equitable access to healthcare, mostly for uninsured adults in immigrant and refugee communities, but increasingly, we know there's the demand there for services for the whole family. So we do a lot of advising parents and referring parents to services as well for their children. In the past year and a half, we've served 740 unduplicated individuals, which I'm very proud of. Most of them came from Latin America. The next largest proportion came from Southeast Asia, and then people coming from Central Africa and West Africa were our next largest group. And we also work with many people from the Middle East and North Africa, Arabic speakers. So here is our team. And I think I will leave it there for now so you can look at our beautiful team. And Catherine, I'm happy to take a couple of questions.
Thank you so much, Kelsey. That was wonderful. The first question we have is actually this is a question from someone who could not attend, and it is kind of a general question about immigration. It's an interesting one, and we're going to throw it out to you. It does not directly have to do with health. This is a person who says, I am a Black person originally from Panama. I speak my native tongue, which is Spanish and English. I'm proud of my Latin heritage as well as my African roots. However, I'm always lumped in by all people as African American. This comes from Blacks, whites, and other Latinos. Am I wrong for being slightly offended by this?
Oh, wow. So, I mean, I think what I can say first of all is you're not wrong for feeling what you feel, because it's your identity, and you get to define that, and you get to decide the terms and the words that are best at describing you and your experience. What I can say, I mean, again, I am a white woman. My family is not recent immigrants, and so I speak from that perspective, informed by the many people of color working around me in immigrant and refugee communities. I think you're not alone in those feelings, and in sort of the feeling like, okay, there are these labels, I don't really fit with this. For a lot of people, and we've had some good conversations recently at CNNC about this, that experience of racialization into this US system of racial categories is something that's really disorienting for a lot of people when they come to the US. And there's good work starting to go on around this in Greensboro. And thinking of two professors at UNCG who actually presented to us as a staff, Dr. Christina Young and Crystal Dixon, both professors in the the Department of Public Health Education at UNCG. They are wise people who've spent a lot of their personal and professional time thinking about this very issue. And so you may want to look up some of their work. I can also just say that, having worked with Spanish speakers and people from Latin America, that often people just prefer to go by their country of origin, like, I'm not Latino, I'm Mexicano, or I'm Hondureño, or I'm Panameño. So I think there are any number of ways to identify, and I hope you'll reach out to CNNC if you want to just talk to people more about that and see what other people have decided for themselves.
I think that's a great recommendation. And I actually worked in Mexico, and I ran into the exact same thing. People did not like being called specifically Hispanic at all. And they preferred Mexicano a lot, much preferred than anything else. So
yeah, we're talking about categories that were created for other purposes besides like our own self-expression and our own like relating our experiences, right? So yeah, that makes total sense.
Really does. This person they had a secondary piece to this, which actually you covered essentially, which was that especially when they go to the doctor, they actually were trying to hide their accent so that they would not be judged. I think you actually covered a lot about this. Do you want to expand a little bit on the unfortunate and sometimes inherent or maybe inadvertent racism that people might experience at the healthcare facilities?
Yeah, I can speak to that. I guess things that I've observed are people perhaps not wanting to take the time that, if someone's accent is different than your accent, you might need to listen more carefully or take more time or politely ask someone to repeat something. And not everybody is comfortable doing that. And not everybody, if you're working in a really busy clinic, maybe you feel like you just don't have time to do that. So you go about your business and assume you got as much as you needed. And that's just, the way it goes. Again, part of the cultural humility is, stopping to listen and checking for understanding, right? Not just assuming you understood someone or that they understood you, but really engaging in a conversation about that as a best practice. And I find that asking, was there a specific question about like something to do, or just more a general comment about this being something that's
I think it was just a general comment along with what they were experiencing. We do have a question from our lovely attendees. So this person asked, how much does immigrant healthcare cost and who pays for it?
Okay, interesting question. So there are people who do very detailed analyses of the sort of economics of healthcare and demographics, and I am not one of those people since I'm a community practitioner. But I mean, to be general, Yeah, so I don't have a number of like how much immigrant healthcare costs, because I think that also requires us getting into a lot of categorization about who is an immigrant and who isn't, and how do we break those people out when we're looking at costs, expenditures. But to be brief, the same way that the rest of our healthcare gets paid for. So it's a combination in this country. It's private funds, it's public funds. Immigrants pay taxes, just regardless of immigration status. They're paying into the tax system. And so publicly funded programs like Medicaid and Medicare are paid from those taxes, keeping in mind that if you are an unauthorized immigrant or you are a legal permanent resident who has not lived here for long enough, that you may never receive any of those benefits that you're paying into, but you are paying in for them to help cover the cost of my healthcare when I turn 65, for example. And then otherwise it would be, you know, private sources, so private health insurers who cover people of immigrant backgrounds. Many people pay for things out of pocket, hopefully at a reduced cost when they're able. So just like any other healthcare, it's a combination of private and public money that pays for it.
We have a question who one of our audience members just asked, but I was about to ask it as well. So I am so grateful to Brenda Madden for asking this, which is how are volunteers utilized at CNNC? And I was also going to ask, of course, how can our community members get involved with CNNC?
Yeah, absolutely. So go to our website, cnnc.uncg.edu. All the letters are there. We do have a volunteer coordinator who's one of our AmeriCorps members each year, who is the primary person fielding volunteer requests. Yes, AmeriCorps alum right here. So yes.
Me too.
Awesome. So that person is the first point of contact. I will say that right now, as the COVID situation continues to evolve, we have relatively fewer volunteer opportunities than we do in normal non-pandemic circumstances. So we're still working that out. But in the past, volunteers often have worked with our community centers primarily. So working with after school tutoring, you know, being mentors to children and youth, helping with other tasks around the centers. With the Health Access Project, it's been much more limited. I do have a couple of volunteers this year who are pre-health professional students, so pre-dental student and a pre-med student, who have been able to help with some special projects around COVID, such as creating infographics and helping us gather information about resources in the community, sometimes making calls to clients about specific events coming up, or helping us with socially distanced mobile flu clinics. So we've done a few things like that. But if you're interested, be sure to check out the website, contact the volunteer coordinator. I should also note that we are actively recruiting AmeriCorps members for the coming year. So looking for people to start in August, and that is a position that includes some education award and a stipend and some other benefits. So be sure to check that out on our website too, if you'd like something a little bit more than a volunteer position.
And we have just about run out of time, unfortunately. But I actually think that that is one of the most perfect ways to end anything, is to pump up AmeriCorps. We do have one final small question, which is about who funds CNNC?
Sure, absolutely. So while we are situated in the university and a portion of our funding, a small portion comes from the university, we write a lot of grants. We work with local and state funders. We receive private donations. We also have 2 revenue generating programs, our interpreter bank and our immigration services program. So we are generating funds in that way too. So a combination of those sources.
All right. Well, I think that just about wraps all of it up for us. Thank you so much, Kelsey, for joining us today. You have been a absolutely fantastic panelist. And we also have another webinar upcoming on March 16th. That is another Tuesday at 6 p.m. This will be part 2 of New in Town, Immigrants and Refugees in Guilford County, where we will be discussing the refugee experience directly. Attendance is always free to Greensboro History Museum programs, unless otherwise noted. However, please don't forget to register. You can go to www.greensborohistory.org or the Greensboro History Museum Facebook, Instagram, or Twitter platforms to learn more. I really appreciate everybody being here with us today, and we hope to see you all again in 2 weeks. Thank you so much, Kelsey.
Thank you, Catherine. Thanks, everybody.
And we'll say bye to all of our attendees here. Bye, attendees. Oh, yes, and I apologize. Join us for our democracy lunch table on Friday at noon. We often are hosting fun programs on Fridays at noon. Little things that are kind of short one-offs. They range from everything from Vicks Vapor Rub and the story about it to ghosts in Greensboro. So it is a wide range for that particular very fun Friday at noon experience. I hope everybody enjoyed. Okay.
Job well done, ladies. And thank you, Kelsey.
Thank you, Rodney.
Or Kelsey Lee.
Her video stopped, but I don't know. She might have signed off.
I think she might be gone. There was another. There was 2 boxes open. One just had her name. The other one had her voice.
Yes.
All right.
Did we stop?
You want to stop the cloud recording? Yes.
Yes. I was going to say we need to stop YouTube. YouTube's still running.
Yes, I'm going to do that as well.